So I forgot to wrap this one up under TBI. So as I mentioned, TBI and hemorrhagic stroke share the same management. Why is that? Anyone have an idea? Why is it the same? Brain injury, traumatic brain injury or head injury, and then hemorrhagic stroke. Why is the management the same?
Because it has to do with the brain and the same how do you say, the symptoms and effects will happen, such as cerebral edema.
Okay, very good. So it deals with the same thing. So in TBI, the cause was trauma, right? In stroke, it wasn't trauma. However, it still involves bleeding, and therefore this is both intracerebral bleeding. So therefore, the management is is similar. Both will have compromised cerebral perfusion pressure. We discussed this extensively already in the past week. So you know how to calculate CPP, which is MAP minus ICP. Now, regarding how do we, nobody asked me, how exactly do we measure ICP? Now, this is done through a variety of ways, but the most common way to measure ICP is to drill a small hole into the skull and then insert an intraventricular catheter. Let me show you a picture. It's also called an IVC. Okay, can you see the illustrations?
Yes.
So here is the most common way to do it. So this is the insertion site. The doctor will use his two hands to locate this position, this site. He'll make a triangle with his fingers, starting with the forehead, and then in the middle will be the insertion site. So they won't shave, but they'll clip the hair, okay, because we don't really shave incision sites. So they'll clip the hair and then drill a hole through the scalp and then into the skull. And then they'll insert a catheter into the ventricle of the brain. So I showed you ventricle positions last week. So the catheter will be inside there, and then this will be connected to a device which looks like this. So it's a series of tubings. And where do we put this tubing? We put it on an IV pole. And the key here is, you know what a level is, yeah? You know, a leveling tool. Do you know what that is? When you hang a picture on the wall, you need a level. That way, it's straight.
Mm-hmm.
You know what I'm talking about? No,
Yeah, it looks like a ruler. It looks like a ruler
yeah, a tool that has water and a bubble in it.
in the middle. Yeah,
Correct.
and then it has to be even.
Right. So this device has something like that. So we need to put the measuring device on an IV pole, and it has to be level with the insertion site. Now, this is crucial because if the level is not straight, then your measurement for your ICP is inaccurate. We need an accurate ICP measurement in order to, because think about it, if your ICP measurement is incorrect, then what is your CPP measurement? Is it correct?
No.
No. Okay, so it's really crucial that it be accurate. So it's not nothing complicated. So all you need to do is level, make sure the device is level with the insertion site. Now the benefit of this technique, because you can also put in bolts, screws, um, to do this, but the most beneficial is the catheter because you not only measure the ICP, you can also drain the CSF and blood from that catheter. So it's a dual purpose. So you're not only measuring ICP, you can also decrease ICP by draining some CSF and draining some blood out of the catheter. Any question about the idea?
No.
Okay. Now, the problem is the complications with this procedure is with having this equipment is it's invasive, correct? So therefore, and the scalp, will the scalp, I know we remove the hair, but will hair stay short?
No.
It will grow. Yeah, it will grow over the next few days, and we don't know how long this patient will require this equipment. So therefore, the hair grows back, and then can you really keep something with hair clean? No. So what's a complication for this type of instrument?
Infection?
Okay, so we could have infection in the form of meningitis. So review your meningitis signs and symptoms from a peds. Okay, it's really not different in the adult. So you have the fever, nuchal rigidity, the mental status changes. Okay, um, so that's the way we measure ICP. Okay, we discussed already. This is one of the 6 secondary injuries that could develop when the patient has head injury. So primary injury occurs at the time of the event, but then they will develop cerebral edema, herniation, and then because the brainstem is herniated, then we'll have to deal with impaired oxygenation because the respiratory rate drops, blood pressure and heart rate is affected as well. And here's again the summary. We already saw this in stroke, if you remember. It was in a paragraph and there were several bullets. So here it is again, but in a chart now, chart 63-5. So no different from what you saw under the stroke section. Now remember diabetes insipidus and SIADH last semester?
Yes.
Okay, what were the causes, if you remember, what were the causes that lead to diabetes insipidus and SIADH? Because remember, those two did not occur alone, meaning those are not primary diagnoses. They were complications, yeah? So what did you remember were the causes that leads to DI and SIADH?
It's the brain tumor, brain trauma.
Correct. So it was stroke. Yeah, it was stroke, brain tumor, brain trauma. So here it is again. So in people with stroke, whether it's hemorrhagic stroke or TBI, for instance, you watch them for those two complications because it could go either way. So they can either have diabetes insipidus or SIADH. And then because of the increased ICP, now the patient now has seizures. Okay, they are at risk for seizure because of the increased ICP. So if we cannot control ICP by these means, then the patient will most likely sustain a seizure. Now that can be devastating when the patient has head injury. So what do you think will be given again? So every TBI patient, and keep in mind also, the surgery that we perform in order to evacuate the blood and stop the bleeding in hemorrhagic stroke or in TBI, is that traumatic in itself?
Yes.
Yes, so brain surgery is a form of TBI, yeah? But it is, of course, controlled. Okay, we do not intend to inflict trauma to the brain, but we have to because we have to evacuate the blood. So when we perform surgery, it is a form of traumatic brain injury. So therefore, we expect certain medications to be administered. So based on what we described so far, what will be some medications routinely prescribed after TBI, including after brain surgery? Give me a few.
Antibiotics
Very good. Why antibiotics?
to prevent infections because you're going to be drilling a hole in the patient head.
Right. So the surgery, or whether we open the skull or we inserted the intraventricular catheter, means the patient is at risk for infection. So antibiotics will be given. What else?
Steroids.
Very good. Be specific about the steroid. What's the purpose of the steroid here?
To reduce inflammation.
Very good. To reduce edema and inflammation. So it was mentioned up here. So there is cerebral edema here. So in order to decrease that, we can administer steroids. So name the steroid that will be used in this particular scenario.
Betamethasone.
Dexamethasone. Okay, so that's the standard for whenever we have some brain tumor or brain surgery, that is the preferred steroid. So we expect to administer dexamethasone. So antibiotics, dexamethasone, and give me two more.
Diuretics or product diuretics.
Okay, mannitol specifically. Okay, mannitol will be given. What else? Right here. Green.
Seizure meds.
Okay, so for seizures, the doctor usually will administer levetiracetam, which is Keppra, or phenytoin. But between the two, the more frequently prescribed one is levetiracetam, which is Keppra. And because these patients will not be moving, for a while, they'll be bedbound. So give me two more that will be given. But this could be a select all that apply question.
Anticoagulant.
Okay, for prevention of DVT, very good. And then last one more. Another prophylactic medication. Because this is a stressful event, So this is a stressful event and puts the patient at risk for one more thing.
The H2 blockers to prevent ulcers.
Very good. So if the patient will not be given a nasogastric tube, definitely they'll be given either PPI or H2 receptor blocker, okay, to prevent peptic ulcer or gastric, the stress ulcers. All right, and that would be the conclusion of TBI and surgical management of stroke. Any question before we proceed to Parkinson's? Very good, children. Okay, let's go to Parkinson's now. So we leave the acute problems. Let's go now to chronic degenerative disorders. Parkinson's disease. So you've heard of people having this sad disorder. We have a few celebrities, famous ones that are living. Some have already passed. So what is Parkinson's disease? So it's a slowly progressing neurologic movement disorder. Now, this is different from multiple sclerosis. We'll discuss the latter one a little bit later. So the difference between the two is this one affects a particular part of your brain that produces and stores dopamine, which is the substantia nigra. So again, this is a slowly progressing neurologic movement disorder. Now, why movement? Because dopamine, you've seen dopamine in shock. So what was the purpose of dopamine, giving dopamine in shock? To raise
The blood pressure.
Raise blood pressure, yeah? Now, dopamine is also a neurotransmitter. So it is a neurotransmitter for muscle, the transmission of impulses for muscles to function. So since it's a neurotransmitter and it's produced in the substantia nigra of your brain, now this part of the brain is the one that deteriorates. So this is part of one of the degenerative or disorders of the brain along with the dementia. So the degeneration of this part of your brain results in low dopamine levels. Now, what is the purpose of dopamine? Let's review. So this statement here gives you the distinction between dopamine and acetylcholine. Now, you remember when we talked about myasthenia gravis last semester. Now, in MG, what was the problem in myasthenia gravis again?
Muscle weakness.
Yeah, it was an autoimmune disorder, correct? So when our antibodies attacked what specifically? What did our antibodies destroy in MG?
Acetylcholine receptors.
Very good. It was the acetylcholine receptor site. There was no problem with the acetylcholine production. The problem was with antibodies destroying the acetylcholine receptor sites. So here, when we move our muscles, two things were needed in order for electrical impulses to travel. So we need acetylcholine, which is responsible for muscle contraction. Dopamine enables us to control it. So if you think about it, acetylcholine is the excitatory, makes muscle movement possible, but we need dopamine in order to control it. So this is the inhibitory part. So as long as these two are normal in number and function, we will have coordinated muscle movements, no problem with motor movements whatsoever. But in this case, there's enough acetylcholine, there's enough receptors, but the patient does not have enough dopamine. So therefore, there is no inhibitory function in muscle movements. Now, the result will result in the symptoms of the patient's manifestations in Parkinson's disease. So here, the loss of dopamine results in more excitatory neurotransmitters than inhibitory transmitters. Now, the patient will have the tremors here. So you notice Michael J. Fox on TV. Yeah, if you watch TV, how does he look on TV? He has these movements like he does, right? This, and then his hands, and then and sometimes he also we'll know more, we'll understand more when we get to the medications for Parkinson's. Now you'll notice that the patient will do this. Okay, they'll have shaking, like those little doggies that we put on the car, the bob heads, like bubble heads. Yeah, so they have this bubble head movement. Okay, not just with the head, but also with their arms and their hands. So we have an acronym for our Parkinson's disease, the symptoms. The acronym is TRAP, right here under clinical manifestations. TRAP. So TR. Let's change bradykinesia to akinesia because it can be either. Can be akinesia or bradykinesia. And then there is postural instability. So that's the acronym. Patient has tremors. There's rigidity of the muscles. There's bradykinesia or akinesia. Brady is slow movement. Akinesia is no movement. And then postural instability. So they have this forward-leaning posture, and they will walk in a propulsive gait. They will look like they're gonna fall flat on their face when they walk. Okay? They have this shuffling plus propulsive gait. Here, so shuffling gait is when they cannot lift their feet off the ground. So it's like they're dragging their feet on the floor when they walk. They are in a leaning forward position. So that's what we call shuffling gait or with a propulsive gait. There are, of course, other manifestations as a result of decreased dopamine. One of them is blood pressure problems. So they'll have orthostatic hypotension. They'll have the following also: drooling, sweating, paroxysmal flushing, and they'll have bowel and bladder problems as well. And finally, sexual dysfunction. So this can occur in any age. Actually, it used to be majority of the patients were elderly. But Michael J. Fox, he was only in his early 40s when he was afflicted with the condition. So this is basically going to affect more than just old people. Any questions so far? All right.
No.
So those are the, yes.
No, no
Okay.
questions.
All right. So diagnosis, of course, we have a list here. Now, it's the diagnosis is made clinically based on the patient's clinical symptoms, okay, the TRAP, and then also the an MRI of the brain, because we need to distinguish, although not all, but some patients with Parkinson's disease, sorry, have or sorry. These patients will develop dementia eventually, but some of them develop dementia sooner than others. And of course, the PET scan or the CAT scan will show the deterioration of the substantia nigra, and blood tests will show low levels of dopamine. Management, this is basically managed with medications. There's nothing else we can do here. This is not autoimmune, this is degenerative. So there's really nothing else besides medications that we can do. Now, the medications you see here may look familiar because we discussed some of them in myasthenia gravis already. And some of the medications will also be shared with other disorders because these patients, as you see here under the other manifestations, they have this muscle spasm, so they will be taking muscle relaxants as a result. So let's begin with the most common. Now, most patients will start with levodopa. Now, levodopa usually is not given alone because you heard of the blood-brain barrier, correct? What is the purpose of the blood-brain barrier?
To prevent medication from getting into the brain.
Okay, so not only medications, but certain toxins, yeah, and then organisms as well. So it's a protection in the brain circulation. So this applies to medications as well. So usually when we give levodopa alone, most of it will be destroyed. Now, levodopa is dopamine. Okay. Now, levodopa will be destroyed as it crosses the blood-brain barrier. Now, to make more of it available, it's never given alone. It's been given with carbidopa. So the drug Sinemet is actually levodopa carbidopa. So it's two. And here's the purpose or rationale why carbidopa is given to levodopa: to avoid metabolism of levodopa before it can reach the brain. So they have to be given together. The drug again is called Sinemet, Sinemet. So now this is the earliest drug given. It's also the cheapest. So you'll see most people starting Sinemet early in the disease. However, since this is chronic, remember, this is forever. There's no cure for Parkinson's as of now. So therefore, what will happen to you if you're taking the same drug for decades now?
You're gonna build up tolerance to it and it's not gonna do the job.
Okay, so it will happen over time. So what happens with these patients is they will cycle through different medications when they no longer see benefits from one drug, but they'll return to that drug eventually, but we need to cycle it. Here, benefits begin to wane and adverse effects become more severe over time. So this is the reason why we cycle through some medications. Okay, and with this drug, with Sinemet, with levodopa carbidopa, within 5 to 10 years, the patients develop a response, and then they'll have the dyskinesia. You've seen dyskinesia or you discussed it in psych, yeah? You know, tardive dyskinesia, the uncontrollable
Movement.
Yeah, these movements here, facial grimacing, like they'll have the lip smacking and like that. Here's smacking movements. You've discussed it in psych, yeah?
Yes.
Yes.
Patients will have these, like they can't control it. They'll have like this, like that, and then they have certain jerking movements of the hand. So this is common in not just antipsychotic medications, risperidone, those antipsychotic drugs that we give to schizophrenia and to bipolar patients. So same thing here. This is another psych medication. So dyskinesia can also result from treatments for Parkinson's. Okay, so and these can be embarrassing, yeah, when these happen in public, and especially when people around you are not aware of these, or just basically nobody knows that you're taking these medications. So, of course, people stare, and it's just embarrassing for our patients. And here's another consequence of taking the same drug for a long time. They will have what's called on-off syndrome, meaning the drug works sometimes and then sometimes it doesn't work. Now, this can be dangerous because as you'll see back here in the manifestations, the muscles of chewing and swallowing, because remember they have, besides the TRAP acronym, remember they also have the drooling uh, right here. Right here. So they have the excessive drooling, and they'll have problems with chewing and swallowing as well. So choking is a common issue with patients with Parkinson's. So when they have these off syndromes, when they have the off periods, they can literally choke. They can aspirate, and then they'll develop aspiration pneumonia as a result. So these can cause all sorts of complications for Parkinson's patients. And how do we manage this? So changing the drug dosing or switching drugs may help. So that's why, but this is another reason why we cycle through different medications. So when this happens eventually, so benefits begin to wane and adverse effects become severe over time with that drug, then the doctor will simply change the dose or switch to another drug. Any question so far? Now you have to understand this because
No.
because our Parkinson's patients, you may see them in nursing homes, in assisted living facilities, but actually more than half still live at home. They they prefer, of course, any person would prefer living at home, yeah, independently rather than in an institution. But this is the sad reality that they have to deal with. This is also another opportunity for you guys. There are increasing telehealth job opportunities. So one option is to monitor and follow your Parkinson's disease patients, because again, they live at home. So there's a increasing jobs for telehealth. So if you're one of those nurses, you meet these patients online. Okay, you talk through Microsoft Teams or Zoom or whatever video service you'll be using to communicate with your patients, and this is how you monitor their therapy. Okay, so you report to the physician, how your patient is doing. Am I still showing the screen?
You was, but you just went away from it.
Professor, you are, yes.
How about now? Yeah.
Yes.
Yes.
So any questions so far? This is just the first drug. We have many more. We have an entire table. Any question? All right. So surgery, I will not discuss because, I mean, let's face it. Who are the famous celebrities you know that have Parkinson's? Existing or living or
Michael J. Fox and Muhammad Ali.
okay. So have you seen either one get better or were cured?
No.
No.
No. So we'll skip the surgical management because really, yes, these are available. Stereotactic procedures. um, Here, okay, so we have, this is the stereotactic procedure that they're talking about. None of them really work. So the most successful management remains the medications. All right, so we'll skip that. We'll skip these surgical options. So here's your complete testable table for exam 3 on Parkinson's disease. So we've got anticholinergics. Between these two, I will use this one because I've really never heard of this one. So we only see, I mean, at least I see only benztropine. So between the two, it'll be benztropine. All the rest are testable. So the only one we're not testing is trihexyphenidyl, because I'd never really seen this in practice. So every drug here except trihexyphenidyl. Are we clear? But this is not the first time you've seen anticholinergic agents, yeah? I mean, you've seen atropine, correct?
Yes.
Yeah, so that's an anticholinergic. So really, they have the same, because it's the same drug class. They're all anticholinergic. So effects and side effects will be the same. So here it's contraindicated in glaucoma because why? What do all anticholinergics do? What's the side effect? They cause fluid retention. Yeah.
Retention. Yeah.
Yeah, so they cause fluid retention, they cause bladder distension, urinary retention, they cause
Dry eye, dry mouth.
increased heart rate. Yeah, correct. Blurred vision, dry mouth. And then we have amantadine, antiviral. So this is also used. This is actually an antiviral. Oh, right here. Sorry, it is an antiviral. But besides Parkinson's, this can also be used in patients with bipolar disorder and also with certain patients with autism. Okay, adult autism can be put on amantadine as well. So that's the purpose why that it is given to those other disorders. Okay, so this will help control the tremors and rigidity, and these are the side effects. Then for dopamine agonist, bromocriptine, and these are the side effects. And you've got propranolol. It's given early. Propranolol is also given to people with restless leg syndrome. And you've done MAOI inhibitors, yeah, in psych.
Yes.
Okay, so because it inhibits dopamine breakdown, makes it more available. And the COMT inhibitors, so that's the acronym for this one is COMT inhibitors, COMT, entacapone, tolcapone. This will usually given together with Sinemet. Helps make Sinemet more effective. Okay. Most of these drugs are covered by Medicare. So therefore, all insurance companies will cover them as well. Used to be entacapone was very expensive, but ever since Medicare started covering it, and it was a lot better. So patients can. So this is what I mean by the patients will cycle through these medications, okay, over time when the benefits wane and the adverse effects are more pronounced, then they'll just switch through other medications. Okay. Any questions on drug therapy? Okay, so like I said, the rest of the medications will be supportive. For instance, if you're having Parkinson's at your age now, what will you develop? How old are you, Shanice Morris? If you don't mind.
30.
Okay, so if let's say you develop Parkinson's at your age now, what else will you develop?
Depression?
Okay, so you'll have depression. Will you have insomnia?
Yes.
Will you have anxiety?
Yes.
All right, so name that all the effects that it would have on the person, and then you will have to treat you for those as well. And like we said earlier, the patient will develop orthostatic hypotension, yeah? So that will have to be managed as well. We'll have to look at the patient's blood pressure. Now it's not just the doctors and the nurses here. Which other collaborative team members will be involved here? In this, especially if the patient chooses to stay at home.
Occupational therapy?
Who else? Very good.
Physical therapy?
Who else?
Social work?
Who else? No, let's start. Let's finish the physical first. Remember,
Oh, okay.
drooling. There's high risk for aspiration. So who takes care of that?
The speech
Speech?
therapist?
Speech therapist.
Okay, the speech language pathologist will also be involved here. Okay, so it's a multidisciplinary approach. So here we talked about you guys mentioned the PT and the OT will also help. And then for the nutrition, the speech pathologist will be involved to design a diet for these patients because they'll have chewing and swallowing problems, so they'll help very well with that. And then with communication as well. And you need, if needed, because these patients eventually will develop depression, so there will be a psychiatrist involved now until the next time these patients get admitted. Now, the reason for hospital admission are really complications from the disease. Usually they develop pneumonia. How do they develop pneumonia again?
I'm not being able to like swallow properly and stuff like that.
Okay, it will be from
Is that
correct. So they aspirate and then develop pneumonia. Or let's say these patients choose to, just lay in bed. Usually they do that when they get depressed. So they now in bed, don't get out much. And then now they develop pneumonia from that as well. And then there also be UTIs because, the drugs cause urinary retention. Yeah. So if you're taking benztropine or another anticholinergic, so they'll have UTIs from that. And then, so the disease technically, they don't die from Parkinson's, they die from the complications related to Parkinson's disease. So it's one of the frequent causes of hospital readmission is pneumonia, the aspiration pneumonia, and then the UTI. And you already know what will kill them when they have pneumonia or UTI. We discussed this in module 1. So they will develop what?
Septic shock.
Correct. So they will develop sepsis either from pneumonia or from UTIs. So any question on, and this is the discharge, right? So that's why you can understand why these people will be put in an institution, right? Unless they have, adequate resources. If they're rich enough, then they can stay at home. Right. Any questions? Now, over time, besides dementia, that they'll develop dementia, these patients will also develop psychotic episodes because they'll have hallucinations, and that can lead to psychosis. that's it for Parkinson's. You need a break?
Yes.
Okay, I'll see you at 11:30.
11:30?
11:30.
No problem. Thank you, Professor.